This is the Psychcast by MDedge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and inspiration straight to your ears with new episodes dropping on Wednesdays. And welcome to episode 124 of the Psychcast by MDedge. I am the voice of MDedge Podcasts, Nick Andrews. This is the official podcast of MDedge Psychiatry. And for episode 124, we want to bring you the best of our COVID coverage. I hope you and yours have a happy and safe holiday if you're celebrating the birthday of the United States. And we hope you stay safe and socially distanced as it's relevant wherever you are. And welcome aboard for our international listeners who may or may not be celebrating American Independence Day. Remember, you can email the show at podcasts@mdedge.com. You can also follow us on Twitter at MDedgePsych. We will be back with a brand new episode following the holiday. We thought that covering the best of COVID was the most relevant thing to do. We covered COVID pretty extensively. It has a lot of tentacles in psychiatry, including telepsychiatry and what you can tell your patients about anxiety and what you can tell your colleagues about having anxiety and working this day and age. And I think if you're new to the show, this is a great place to start. It kind of shows what we do and what we're all about. And it's a great place to start with all of your COVID coverage as it pertains to psychiatry. So we're just going to click play and then let this best of episode happen. Remember, email the show if you have any ideas, and we'll be back with a brand new episode in episode 125.
This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. We're privileged today to have with us Dr. Preskorn. Dr. Preskorn is a professor of psychiatry, and he is going to speak with us about COVID-19 and how we can maybe as psychiatrists understand some of, if you will, the manifestations, the maybe a bit of the epidemiology around COVID-19 in a way in which we can actually speak to our patients about this and answer maybe some of the common questions that they may have regarding COVID-19. So if you're like me, COVID-19 invariably is a topic that comes up in your in your psychotherapy sessions and your psychopharmacology sessions. So hopefully this, if you will, podcast will give you some additional tools in which to think about and engage in those conversations with patients. Dr. Preskorn, welcome to the MDedge Psychcast.
Thank you, Dr. Norris.
Okay. So Dr. Preskorn, one of the things that comes up in regards to COVID-19 or coronaviruses in general is, how did we get here? What is the, where did this come from? People have a difficult time understanding it. How is it different from other coronaviruses they may have heard? And maybe you could walk us through maybe how you might approach talking with a patient and helping them understand what coronavirus, COVID-19 in particular, is and is not. Okay.
Very good. Well, so the history, first of all, one thing one should know is there are hundreds of coronaviruses. They primarily infect animals, and particularly bats, but a number of other mammalian species. There are 4 coronaviruses that have been known to infect humans for years and probably date back to the 1200s. Those 4 coronaviruses are one cause of what we know as the common cold. However, things changed in the year 2000. Mm-hmm. And from the 2000s to today, we've had 3 coronaviruses jump from animals to man. The first was known often as SARS, or sudden acute respiratory syndrome virus, now known as COVID-19. And it was quite lethal, killing about 10% of people. And one was concerned in the early 2000s that it might become a pan-epidemic. It was so lethal that probably limited its abilities. About 6 to 7 years later, a second coronavirus of this more lethal type that can cause SARS, which is sudden acute respiratory syndrome, was known as MERS. And it came prominently to our attention in the Middle East, and hence it was known as the Middle East Respiratory Syndrome virus. And the last so far has been SARS, sudden acute respiratory syndrome, COVID-2, which is the virus that causes COVID-19. So that was the backdrop in December and January to the emergence of this virus out of China. And that was the reason for the concern with it.
So Dr. Preskorn, you bring up some, you paint, if you will, the coronavirus history, particularly over the last, if you will, since the 2000s very well. A question that patients may bring up, or I know that they have, is this trying to understand the difference between SARS, MERS, and currently COVID-19. Like, why are we so concerned about COVID-19 as compared to SARS? Because for most people, obviously right now, COVID-19 seems to be having a much more impact on their daily life than SARS or MERS. So that's a question that people may get from their patients. Why is COVID-19 such a big deal? Whereas with SARS and MERS, it felt like a big deal, but we didn't do all of this. I mean, how would you approach that with patients?
The difference is there are three main differences with COVID-19 or SARS-CoV-2. Mm-hmm. One, it is highly transmissible. Mm-hmm. It will infect, for every person infected, they will infect up to 6 additional people. That was much more so than with COVID-1 or MERS. 2, this virus is sort of sneaky. It stays hidden, and you can be infected for many days and shedding virus before you're ever symptomatic. And that's the reason why it can be subtle and can sneak in. And 3, it is much more, it's not as lethal as the other 2 viruses, which allows it to propagate, whereas the other viruses killed the host before they could propagate. And so it has 3 features that make it dangerous: highly transmissible, a long period between shedding the virus and being symptomatic. So you can't count on the person being asymptomatic to mean they're not infected. And 3, while it doesn't kill most people, it is very lethal in individuals who are elderly or who have comorbid medical illnesses.
Yeah. All right. So when I think about that, and I think about what you just outlined in terms of coronaviruses and colds, and I'm just trying to, if we can play around with this in terms of maybe some things that we might tell patients, depending on where they're at in terms of either their emotional state or distress or cognitive function. But I think about coronavirus as, just listening to you, this is what I think, like, it's as at least probably, if not more so, but certainly, I would say it's certainly in the same vein as contagious as a common cold. All right. In terms of that, I would also say that it is more lethal than the flu. And then the other thing is, I like that word you use, it's sneaky.
Yes.
All right. It's sneaky. So we can't see it the same way we could the flu or the cold. And that's what makes all of those elements are what makes it so dangerous. So it's not the cold. It's not the flu. It's a sneaky thing that sticks. That kills more people than the flu. And that's why we're so concerned.
Yeah. Now it kills more people in special populations.
Okay, excellent. Yeah, let's break that down.
So in seasonal flu, in younger individuals, people under the age of 50, it probably is not substantially more lethal than the seasonal flu. But in individuals as they develop comorbid medical illnesses, now when I said under 50, I mean under 50 and no comorbid medical illnesses that put you at high risk. And there are essentially 4 or 5 comorbid illnesses that put you at substantial risk. That's respiratory disease, including COPD, emphysema, and even severe asthma. Cardiovascular disease, particularly hypertension, morbid obesity above a body mass index of 40, and diabetes. And then the other is if you're immunocompromised. So if you're on steroids, if you're on drugs to suppress your immune system, those individuals, regardless of age, are at increased risk. But in addition, as you get older, you get at more risk. And so, for example, above the age of 85, your risk of dying from COVID-19 is between 10 and 27%. So it actually gets as lethal as COVID-1 and MERS in that population. And the trick is, and what patients need to know is that even if they're asymptomatic, or if the person they're visiting with is asymptomatic, they may be shedding the virus. And if they're in those high-risk population, if either they're visiting somebody who's in high risk or they are at high risk, they have to take extra precaution. And unfortunately, they cannot count on the fact that the person is not symptomatic to indicate that they're not infectious.
All of us, in the way our society is being virtualized and the changes in society in the last decades with technology, I think we're all moving to what is termed hybrid relations. And this means that we hold relations with human beings in multiple mediums and spaces. We have relationships in our personal lives, both in person, over telephone, over social networking, over texting, over email. And in our professional lives with our patients now, we interact with our patients not only in person, but we are now interacting with them, of course, over video conferencing, patient portals, texting, email, phones. And so these hybrid relationships can be new to some practitioners about how to manage them. And within that, within hybrid relationships, there's this concept of virtual space. This space we interact with people that's not in person. And there are certainly there are significant differences between interacting with patients and others in physical versus virtual space. Starting with physical space, it's really been the traditional gold standard of how to interact with patients. There's an immediacy and trust in interpersonal interactions when being in the same room with someone. The physical boundaries of being in the same room with someone can set sort of a therapeutic frame. And there is a lot of research, practice guidelines, decades and literally centuries available about how to work with a patient in person. Virtual space is relatively new over the last 2 decades, although there is a growing body of work, evidence, and research telling us how to do it. Some of the advantages is that it can be convenient and immediate. It may create a little more sense of space for the provider and the patient. That sense of space for the provider can help them gain a little bit of what you would consider maybe an observing ego in the clinical situation. For patients, it may give them a little bit initially of a feeling of distance, emotional distance from the provider, but it may help patients, particularly with PTSD, anxiety, other avoidant behaviors, feel more comfortable and more control on their end of the therapeutic session, and allow them to engage more in treatment. It's certainly, you can offer more flexibilities and off hours care, and especially treating patients in their homes. You are rendering treatment in the environment in which a patient lives, and it gives you a little bit more information. Not only are you seeing how the patient's dressed, but you're getting to see their home environment, and may help you with assessing the patient and developing more specified treatment. So it may also, for the patient, decrease stigmatization, because they're not having to come into a specific clinic. So again, may decrease that barrier to care, and it may make them, that virtual space may allow them to open up a little bit more. There's a term called virtual disinhibition that you often see with technologies, where people tend to be maybe a little more open than they would be in person. So those are some of both the risks and the downsides and the upsides of virtual space. Some of the basic do's and don'ts when video conferencing is making sure that the room that the provider is working in is secure and private, with doors and windows closed. And that's true for the room that the patient's in. Making sure that you always introduce others in the room with you, or ask to be introduced to anyone in the room with the patient. Make sure they're in line of sight. Sometimes you can be video conferencing with a patient and not see everyone in the room, so you may want to set that up front when you're meeting with patients. Keeping the room well lit on both ends, so the patient and provider can be seen. Making sure the webcam is placed appropriately above the computer screen, not below or on the sides, so there's a good eye contact between the provider and patient. Not sitting too far or too close to the camera. Your head should take up about 2/3 of the screen. And then I think one of the most important things to remember is that often, as a provider seeing someone over video conferencing, one may feel that you have less control over the clinical setting. I sort of feel that you give up the illusion of control. I would argue that one doesn't have any more control when you're seeing a patient in your office. And so providers need to make sure that they're actively managing the room and the setting. And so that means not being too passive over the video. If you need a patient to close the door, create more privacy, or need to be a directive, ultimately the provider is responsible and should be proactive. In terms of adapting a personal style to video conferencing, you want to animate yourself a little bit more than you would in person to come across the screen. You want to use picture to watch how you're coming across on the other end in terms of your body language and perception, where your gaze is. It may be necessary to increase the small talk a little bit, not disclosing anything or crossing any boundaries with conversation, but doing things like asking about the patient's environment and setting, not only the room they're in, but what may be going in, particularly if they're not located in the same city as you. For example, what their current weather is, what's going on in their home environment. Really working to bridge that virtual gap and make that connection over video. And then, as always, as you would in person, having a very active listening stance and having a lower threshold to inquire how the patient's doing, how they're feeling about using video conferencing. If you're feeling, if it's difficult to read someone's emotion, asking them, just checking in. Hey, I noticed, are you feeling a little sad? It looks like you're feeling a little sad. So a little bit more active inquiry can be helpful.
So, I think, we're going to talk about how clinicians can help their patients with anxiety and also how to help ourselves, because I feel like that's coming up more and more.
Yes.
But I did want to talk to you first about transitioning your practice to teletherapy, because I know that is it causes a lot of concern for providers, and you were 100% in person and now you're 100% teletherapy. So if you could tell us about that, I'd want to hear about your experience.
Sure. So it's been a learning curve. And if you had talked to me 4 weeks ago, I'm now in my 4th week of practicing remotely, it would have been a different story. I was really anxious about how this was all going to work. And I was trying to get up to speed with informed consent and sending all of my patients that kind of information. I had already used a HIPAA compliant telemedicine platform. Not very much, but I had used it occasionally, called DoxyMe, which I think probably most medical providers are using now. It has been very overloaded, and occasionally the transmission breaks down. But lately it's actually been pretty good. So I don't know if they've made some changes to accommodate the volume or what, but I'm not having problems with it. I don't consider myself an orthodox ACT practitioner, but I use a lot of the ACT techniques. So the acceptance and commitment piece of it is mindfulness and acceptance of what is, things that we can't change, which is very relevant to what we're going through now.
Yeah.
And commitment to valued actions. So using your values as guides. And that, I think, is a really useful framework. It's also a way of doing OCD treatment when we're talking about thoughts that people can't control. So the whole idea is not that you're trying to have people eliminate anxious thoughts or obsessional thinking. It's to be able to accept that they're there and work alongside them.
Yeah, that sounds extremely relevant to now, since it seems like there's not much we can change. And talking to patients about accepting the current situation seems very difficult. Like, I'm really curious to know how you phrase conversations with your patients about, with the anxiety they already have, how do they learn to integrate acceptance of, the COVID-19 sort of, I now call it like COVID world that we're living in. And then how they add that into the treatment that you're already providing for them.
Well, with my patients, because mostly I'm seeing established patients, I have acquired a few new ones, but those are also people who've had previous CBT treatment for anxiety or OCD, so they know the framework. But with the patients that I'm working with, they already know a lot of the techniques. And what I am finding, and I'm sure that this isn't true on a large scale, but what I'm finding among my patients is that they're telling me that they're actually less anxious than they expected that they would be. And what I tell them is that they've been training for this for a long time. So they've been training for uncertainty. They have a lot of tools. And some of the things that are problematic for them are not what we would imagine would be. So with the people with OCD contamination anxiety, you would expect that they would be especially worried. And some of them are, that is true. And we can talk in a little bit about how we manage that and how we contain that. But I'm also finding that people's particular anxieties come up in ways that express their underlying vulnerabilities. And so if an underlying vulnerability is a need for control and perfectionism, people worry about perfecting their quarantine, getting enough done, being productive at work. Yeah. And that can be a source of stress. If an underlying vulnerability is anxiety sensitivity, if they're feeling anxious, they're going to tune in to those physical sensations, and then they might worry that they have symptoms of COVID-19. Or if they have health anxiety, they may be particularly vigilant about those kinds of symptoms. if an underlying issue that they've dealt with is an eating disorder, problems with food scarcity may be triggering for them, and that may cause some binge eating or restriction, either way.
Yeah.
But the underlying, I guess the overarching underlying vulnerability for everyone is an intolerance of uncertainty. And that's something that everybody's dealing with right now.
Yeah, absolutely. So, I mean, listening to that answer, it sounds like we can be narrow and think like it's just going to be about contamination anxiety, but whether you have OCD or not, there's all of these other anxieties that are going to pop up.
Well, not just anxiety, also depression. And I'm finding that more now that we're entering week 4 of shelter in place. People are starting, in the beginning, it was almost a novelty for some people, and they were doing a lot of video chatting with friends and virtual happy hours and things like that. And now people are getting a little tired of that. And some of the restrictions are really wearing on people. And I'm noticing more depression showing up.
Yeah, no, on that topic, I mean, what I've been falling back on a lot more is a work that I did last year in building resilience and trying to get people to think like you have these vulnerabilities, but you also have these strengths. So like during the regular times, like what strengths did you pull from and how can you incorporate those skills into the quarantine? Like life is different, but you still have those skills at hand that you could use, but kind of opening up the blinders a bit, helping them reflect on their past to apply their strengths now has been.
Well, that's actually a great CBT technique. So you're getting people to reframe their thinking and look at it in slightly a different way. So the reality is the same, but the way that they're interpreting it is a little different. And that's the essence of CBT. The other thing that I try to make clear to my patients is that everybody is anxious right now, and that anxiety is actually an adaptive response to a threat. And this is a real threat. So it's not, people shouldn't feel bad for feeling anxious. And when they start feeling bad for feeling anxious is when they start having problems. And it's what the mindfulness people like to call turning pain into suffering. So that you're already, everybody's in a state of pain to some extent. But then when you start beating yourself up for it and saying, I shouldn't be feeling like this, or I should be doing better, or I should be more productive, or I should be getting up at a certain time in the morning and not lying in bed, then it becomes a lot of judgment and a lot of suffering.
Yeah, no, that's a really good reminder. Yeah, the mindfulness, it can be, I mean, it's very useful. There can also be a type of perfectionism around mindfulness, but I also agree that the equation that I was taught in my class of the resistance times pain equals suffering. I think about that a lot right now of like, I just have to be flexible, do what I have to do, trying to incorporate that in treatment with my patients is also helpful.
So when you say perfectionism around mindfulness, what do you see there?
Well, I feel like that's a whole other podcast, but I mean, I think mindfulness is not supposed to be pleasant or unpleasant.
Exactly.
Or meditation is neither pleasant nor unpleasant. It's just something you do. I mean, you can view it as an exercise for your brain or a practice to meta awareness. But I think right now, at least on like the wellness emails that I get from my institution, like, oh, try to meditate, you'll feel better. And I feel that's
the wrong method.
That's the worst of like, if you meditate, you'll feel better. Like this type of like, if you take a warm bath, just like if you meditate, you'll feel better. Like that's not what I want people to take away from mindfulness during this pandemic and this crisis. But I'm afraid that it's kind of been creeping in a lot of the materials that I see across my desk.
Well, we're hearing a lot of things like that actually make me a little concerned. So I'm hearing things like make sure you eat right and make sure you sleep, because those help with your building immunity, and people don't need to feel more anxious about those kinds of things. Yeah. Some of my patients who have some underlying health conditions are really worried if they have high blood pressure. Oh no, I'm stressed. And then they stress about being stressed, and they're worried about the impact of that. And what I tell all my patients about mindfulness and meditation practices is that it's not designed to make you feel better. That's kind of a popular misconception that people have. Mm-hmm. It's really a tool for distress tolerance. So if you're feeling bad, you're allowing yourself to feel bad, but kind of get a little distance from it, or to use the ACT term, to defuse from it.
Yes. Or do you have any other times when you've talked about diffusion with your patients during this pandemic? Because I think that's one of my favorite ACT techniques that you've talked about.
Yeah, I mean, I use it a lot. I don't call it diffusion, but I use it with my OCD patients. And there are different ways of doing it. Thinking about your anxiety as an unwelcome guest at Thanksgiving dinner, and having it but sort of a relative that you don't like and you're annoyed by, but you're stuck with. Having the anxiety just metaphorically pull up a seat and sit down and turn your attention away. Because it's all about turning down the volume. It's not about getting rid of thoughts or getting rid of feelings. It's just down-regulating a little bit.
And that concludes this best of edition of the Psychcast by MDedge. The Psychcast is produced by MDedge editors Gina Henderson and Jeff Bauer. It's executive produced by the editor-in-chief of Medscape, Dr. Ivan Oransky, as well as MDedge executive editors Mary Ellen Schneider and Kathy Skarbeck. I am the voice of MDedge Podcasts, Nick Andrews. The Psychcast episodes that were featured in today's best of episode can be found in the show notes. They are respectively episode number 121, episode number 111, and episode number 113. You can reach out to the show and email us at podcast@mdedge.com, and we'll be back with a brand new episode in episode 125. Hope you and yours have a happy and safe American Independence Day.